Mostafa. Professor Gamal is a professor of surgery at Wayne University, Wayne State University. He's the chief of the surgical department of Detroit VA Hospital in USA. We are really grateful to Professor Gamal for being the speaker in our sessions, and we are looking for more sessions from his side. Thank you very much. We can start.
Thank you. So today we'll talk about one of the series that I started, and this is discussing some of the complications of common procedures. Some of these procedures are performed by surgeons, but sometimes they are not performed by surgeons, but the surgeons will have to deal with the complications of these procedures. And that's what a series that we just started here. And today we'll talk about the two important complications for colonoscopy. So Mohammed, who can we ask a couple of questions here to start with? Can you recommend somebody?
Yes, Dr. Muhammad Ali. He's a senior registrar of general surgery in Sudan. He will, I think he will answer your question.
Right, Muhammad, assalamu alaikum.
Alaikum salam, Professor.
Muhammad, so we just have a couple of questions for you here, Muhammad. What do you think are the two important complications of colonoscopy?
I think one of them is postcolonoscopy perforation.
Okay, and the other one?
Bleeding.
Right, perfect. You're actually absolutely correct. These are the two potential complications of colonoscopy. So we want to ask you three important questions, Muhammad, here, so you can help us with this. And you can see them on the screen here. Does free air after colonoscopy mean perforation? All right, I should say always mean perforation.
Free air after colonoscopy mean perforation?
Yeah, free peritoneal air seen on a plain film, for instance, after colonoscopy. Does it always mean perforation?
I don't think always, but gives great impact on maybe it's a perforation.
But so in other words, can you have free air without perforation?
One of the normal finding after colonoscopy is the free air in the peritoneum.
Okay, so your answer is it doesn't always mean perforation, and yes, you can have free air after colonoscopy without perforation, correct?
Yeah.
You can, correct?
Yeah.
Okay. Does perforation mean an operation? Always mean an operation?
No, not all the time. It depends on the grade, the site, and what type of perforation is.
It depends on the type of perforation and what else?
The site, the type of perforation, the presence of infection.
And what else? I'll take the type and the grade. I'll take those, like the size and all this. I'll take the presence of infection. You mean there is like sepsis or not?
Yeah.
Okay, I'll take that too. I think probably that's, so we can possibly say it depends on the patient's condition, right?
Yeah.
Okay. All right. So if you operate, does an operation always mean a stoma?
Not all the time. If the patient is hemodynamically stable, if there is no, according to the time of the presentation, early presentation, you can deal with it. Late presentation with sepsis, with hemodynamically unstable patient, we can deal with the damage control surgery with the stoma for further treatment in the future.
Okay. Another question that we don't have here related to that. Is an operation always done open?
Not all the time, because a small perforation, if there is experienced person who can deal with endoscopy and the presentation of the perforation on the time of the colonoscopy, he can do just clipping with the endoscope.
Endoscope, right?
Yeah.
No, I mean an operation. An operation. Does it always have to be an open operation?
No, can be laparoscopic.
Okay, so we have 4 questions here. Free air after colonoscopy doesn't always mean perforation. We all agree. And perforation after colonoscopy doesn't always mean an operation. An operation doesn't always mean that it has to be done open. And an operation doesn't always mean there will be a stoma, correct? We agree on all these?
Yeah.
You agree on all this, right? And,
Yeah.
and I think we totally agree on this, and we'll see here. The 2 important things that we should remember whenever we have a perforation or potential perforation after colonoscopy are the 2 facts that the colon is already prepped. You already have a prepped colon. This is really important. It is critical to remember that you already have a prepped colon, mechanically prepped colon with go lightly and things like that. Number 2, which is really important to remember too, that as well, is the pathology in the colon may merit resection regardless. And we'll see about that in the discussion, that you always remember there is a perforation here or bleeding actually, bleeding or perforation, the 2 important complications. There is a bleeding or perforation. And always remember that, do I have a pathology in the colon that merit resection regardless? It's important, because if this is the case, you may just operate. You know why? You may just operate because of A is a fact. What could it be better? You have a prepped colon, it's a clean colon. You have a perforation that's in itself maybe an indication for an operation. And number 3 is you do have a definitive indication for an operation. Maybe they biopsy the cancer and they perforated the colon, but there is cancer, right? There is cancer. You're gonna do an operation. So, or they biopsy the cancer and the patient is bleeding from the biopsy site. You have to operate regardless, whether it's today or next week or 2 months. So why don't you just operate today? Because the colon is prepped anyway. A very important thing to remember, really, and sometimes this is forgotten. Okay. So we just have to remember that colonoscopy is the gold standard for colonic investigation, but it is unique. Colonoscopy is a unique way of investigating the colon. 2 important types of colonoscopy of the procedure itself will always be remembered, and that is diagnostic colonoscopy and therapeutic colonoscopy. Diagnostic colonoscopy, what we mean by that is I do a colonoscopy maybe in a UC or Crohn's disease or something, and I take a couple of biopsies here and there, just diagnostic. Or somebody with average risk or high risk colon cancer, and I'm doing screening colonoscopy. That's a diagnostic colonoscopy. This is different from I'm doing a colonoscopy to take a huge big polyp, right? That's a therapeutic colonoscopy, right? Or dilating the colon. That's also, by balloon dilation or something. That's also a therapeutic colonoscopy. They have 2 different implications, and the mechanism of perforation in both of these is different from each other. And this difference in the mechanism of perforation has some bearing on the way you treat the perforation in these cases. The unique thing about colonoscopy is the only screening method that prevents cancer from happening, not just detecting early. If you compare colonoscopy, screening colonoscopy, if you compare it to mammography, for instance, or PSA measurement for prostate cancer, if you compare it to these 2 important screening methods. Mammography will detect breast cancer early, or precursors of breast cancer. It'll detect them early, but it's not a tool that you can use to prevent cancer from happening. The same with PSA, prostate specific antigen for prostate, for instance, as a screening method. It tells you that there is cancer prostate, right? But it doesn't give you any tool to prevent it. Colonoscopy is totally different. With colonoscopy, you see polyps, and these are benign process. They are not carcinoma in situ. There's no cancer yet. Polyps are benign pathologies for the most part. You take them out, you prevent cancer from happening. Prevent it. So it's not just a screening method, it's a preventive method for colon cancer. All colon cancers start as a polyp. Every single colon cancer we see must start as a polyp first. So theoretically, if you're getting rid of all the polyps in the colon, you're getting rid of all the colon cancer, which is theoretical, of course, because that's not reality, that's not happening. So that's really unique. So along with this unique nature of colonoscopy, it is also the only screening method that has life-threatening potential for complications. Nobody's gonna die of mammogram. Nobody's gonna die of a PSA measurement for prostate cancer. So it's a double-edged sword here. It is unique in preventing cancer, but it is also unique. It's a screening method that can result in a complication that can be lethal, that has some mortality. It's not high, but it's there. So we really have to remember that about colonoscopy. Risk management in this case, the risk of complications can be up to 3 times higher after polypectomy performed by a low volume colonoscopist. Here is the low volume colonoscopist. By definition in different authorities, you probably have to be almost in the 1900, 2000 colonoscopy that you have done. You should have them in your bag, in your pocket, to be in the category of high volume colonoscopist. And if you're in that category, polypectomy, which is a risky procedure, is considered to be safe procedure in your hand. However, if you've only done 200 colonoscopies, I'm not sure you can be considered as a safe colonoscopist to perform polypectomies, especially big one and high risk one, as we'll see. So it is really important. It's very important to put things in perspective here as far as the risk management of colonoscopy. So as the complexity of polypectomy increases, the risk of complications also increases. If you're taking out a sessile, wide base polyp, if you're taking this out in the right colon, which is thin-walled colon, the risk is really high. I don't think you should be embarking on this if you're somebody who just does that very infrequently, and you only have done 400 colonoscopies so far, and you've never done that before. This is a high-risk procedure, so you shouldn't really be doing this, and you should be sending that to somebody else. So it really is important that experience and number of procedures in the past, as well as the high-risk nature of certain polyps, large polyps, wide-based, all that should influence the whether you should be doing that or not. And that comes under the category of risk management in these cases. The two potentially life-complicating complications of colonoscopy are perforation and hemorrhage, as Mohammed just told us. Quickly, we're going to talk about hemorrhage. The management of that is probably easier and more straightforward. So how we define that I did a colonoscopy today and the patient had post-colonoscopy bleeding. This is defined that if this bleeding resulted in hospital admission. So minus plus blood transfusion, but if the patient bled enough after colonoscopy to require a hospital admission, this is going on in a database as a complication, hemorrhage or bleeding after colonoscopy complication. This is the most common complication associated with endoscopic polypectomy. Not with all colonoscopies, but if you are doing polypectomy, the most common complication here is going to be bleeding, not perforation. But I think perforation is more common on all colonoscopies, all comers, but specifically in therapeutic colonoscopy, which i.e. taking a polyp out, which is a unique procedure in itself, as we'll see. Bleeding is the most common complication. What risk factors do we have for bleeding so I can counsel the patient? Right, so we'll go back to Muhammad here and ask him, Muhammad, what do you think are the risk factors? Do you have certain specific risk factors for bleeding after colonoscopy? What would these be?
I can categorize them on two bases: systemic causes and local causes.
Okay.
Systemic causes: patient with hypercoagulable state, patient on warfarin, on aspirin.
Hypercoagulable. I mean, patient with hypercoagulable, or hypercoagulable mean that it coagulates more.
Yeah, but they are on treatment for long duration.
So patient is who's on anticoagulation. Okay.
Yeah.
Okay. Mm-hmm.
The other thing, patient with systemic diseases with low immunity, like diabetes, diabetic patient are prone to bleeding.
Why would those bleed more?
I don't remember now.
No, I don't think they would, right? So, okay. So one of the risk factors is taking anticoagulant medication. Any other risk factors for bleeding after colonoscopy? Other than
cardiac patients.
Why? Why would those bleed more? I don't think they do, right? Okay.
No.
So what other risk factors other than taking anticoagulation? There aren't really that many. Maybe just, you said local things. What local things do you think?
Inflammatory bowel disease is one of the diseases of the colon.
Maybe, probably. So large polyps in the right colon. Okay. In an older person, probably. Large polyp in the right colon in an older person. That's sessile polyp, sessile, large right colon, older age, taking anticoagulation. All these are really real risk factors for bleeding after colonoscopy. So therapeutic, of course, that's the most important thing. Can I ask you what kind of anticoagulation you mean? What kind of drugs that people take for anticoagulation that may affect this?
The long use of aspirin, long use of warfarin.
And what else?
Antiplatelet drugs like aspirin.
Aspirin, Plavix, antiplatelets. Yeah. Coumadin. What's the third category?
Yeah.
There is a third category of medications, more commonly seen now.
I don't know.
Direct oral anticoagulation, right?
Yeah.
Xarelto and all this, the direct oral, direct factor 10A inhibitors and direct thrombin inhibitors that people are taking now, actually more Eliquis and Xarelto and all this more commonly actually than Coumadin, right? Right?
Yeah. Yes.
Okay. So you have three categories of medications. You have antiplatelet medications, aspirin and Plavix, common. You have Coumadin, which is direct vitamin K inhibitor, and you have direct oral anticoagulations. So these are important because we're going to see how important these are. So post-polypectomy bleeding occurs in about, you can probably say a little bit more than 1 in 1,000 to 6 in 100, something like that. It depends on the risk factors. Increased risk, here you are. Older patients, right colon, large polyp, sessile polyp, if you're using cutting as opposed to coagulation diathermy, and if you are using anticoagulation. Very defined risk factors for post-polypectomy bleeding. So just remember that, and you can counsel the patient. These are useful to counsel the patient and say, we have a couple of those, and that means that you have an increased risk of bleeding. The good advice is, it's an important one. If you have really a big polyp, you're about to do a colonoscopy and you have a big, huge polyp, right? You saw a big polyp in the right colon. And you saw a couple of small polyps in the left side of the colon and all this. Take the big polyp only and quit. Do the others later on. And the reason is, if you get bleeding after this colonoscopy, at least you know where it's coming from. But if you've already taken 6 polyps, 6 different sites, left, transverse, splenic flexure, hepatic flexure, cecum, and you have postoperative bleeding, you wouldn't know where the bleeding is coming from. It's a problem. And if you have to operate, now you're in a dilemma. So which one of these actually bled? So really good advice is, take the biggest polyp that has the highest risk of bleeding, take that one out. You know there are others, fine, come and fight another day, but don't do all these in one day. So that will help you localize the bleeding at least if the bleeding takes place. In all cases, patients must be closely monitored, and resuscitation with blood, of course, we all know this. And here is our algorithm of how we manage some of the post-colonoscopy bleeding. Assess the site of bleeding. Endoscopic treatment is almost always successful. It really is a good thing. They can inject epi, they can do hemoclip, you can do direct thermal contact. If unsuccessful, you should probably do a CT angiography to localize that. If this is unsuccessful, then you should consider an operation, and you need to do a segmental resection, something in this direction. So this is probably a clear algorithm of how you manage post colonoscopy bleeding. As you can see, it's pretty simple, probably simpler than the management of perforation. So it's important to consider, remember the first slide we showed, that will colon resection be indicated regardless? Maybe you should do it now because the colon is prepped. You know what I mean by this, guys? Same thing. They took a huge polyp from the right colon. Pathology comes back as tubulovillous adenoma with high-grade dysplasia and positive margin. The treatment for that is going to be ileocecal resection or right colectomy. The patient is bleeding now and you resuscitated and you gave a couple of units of blood. Why don't you just go and do a right colectomy now? Why do you have to wait and say the bleeding may stop, that's fine, it's going to stop, bring the patient back and do a right colectomy? Fine. Why? The colon is prepped and operation is indicated. Stabilize the patient and do it now with one prep, and the colon is already there prepped. So it's just, good thinking. Colonoscopy and anticoagulation, as we talked about. What do I do now? I'm doing a colonoscopy and on a patient, and the patient is taking some kind of anticoagulation, the 3 categories. I need to ask myself some questions. What is the procedure? Am I doing a colonoscopy just for average risk cancer, that I'm just going there to look and see if there's any cancer, but there is no big polyps or anything, and I won't be doing any of this? Or I'm going in and I know there's a huge big polyp in there that I have to take out. That's different. What drug is he taking? Is he taking aspirin Plavix, this group, Coumadin, second group, or the direct oral anticoagulant, third group? And what's the indication for this drug? Is he taking Coumadin for metallic valve, for instance, that I have to bridge if I stop the Coumadin because the cardiologist is not going to be happy with me? Or is he taking the aspirin Plavix for a drug-eluting stent, right? Which I should be covering with some anticoagulation. So I don't have free hand to stop anticoagulation because of my colonoscopy. I have to check with cardiology. 3 questions that we have to ask. The drug can be aspirin Plavix, as we said, Coumadin, or direct oral anticoagulation. Direct oral anticoagulation. The colonoscopy can be low risk, which is just diagnostic minus plus biopsy. Little biopsy of the colon, like ulcerative colitis, and I'm doing biopsy. Or it can be a high risk, like a big polyp. Depends, not all the same. The indication for anticoagulation could be high risk, like stent, metal valve, recent PE or proximal DVT. Or it could be a low risk, maybe AFib without any other risk factors maybe, or really old DVT of the lower extremities, different story. Do I need bridging if I stop the anticoagulation? I'll definitely need it if in the high risk indication as opposed to the low risk. So here is the publication in GUT, the British Society of Gastroenterology and the European Society. They gave us some guidelines of how we manage patients who are taking anticoagulation and need colonoscopy. This is a little bit busy slide and complicated. I'm gonna try and make it a little bit simple for you. But I just want you to remember one thing. As it says up there, low risk procedure and high risk procedure. And look down there if they taken warfarin or direct oral anticoagulation, warfarin direct oral anticoagulation. So remember that. The other slide is, again, low risk, always just colonoscopy biopsy. High risk, today we're just talking about polypectomy. You can ignore the ERCP and all this. This is the antiplatelet group, taking aspirin or Plavix, and in a low risk group and a high risk group. Let's just have some rules. Out of all these slides, we can give you some guiding rules. Number one, never stop aspirin for any reason. Whatever the reason is, low risk colonoscopy, high risk colonoscopy, low risk indication, high risk indication, it doesn't matter. If the patient is taking aspirin, do not stop the aspirin. Go ahead and do your colonoscopy. It's safe, there are no problems with that. Go ahead and do the colonoscopy. Do not stop aspirin for any reason. Number two, do not stop Plavix for low risk colonoscopy. Okay? Patient is taking Plavix, has a metal stent, and I'm only doing average diagnostic colonoscopy because of high risk colon cancer. I'm not taking 3 centimeter polyp from the right colon. Don't stop the Plavix. Go ahead and do your colonoscopy. Number three, stop Plavix 5 days before high risk colonoscopy. Here you are. I'm taking a huge big polyp, right? You can say, how do I know that I'm taking a huge big polyp? Sometimes you don't know. Sometimes you're in and you find that, guess what? If the patient is taking Plavix, don't do it. Don't take the polyp. You're gonna have to bring him back after they stop Plavix. I'm with you. But if you know that there is a big polyp that needs to come out, you have to stop Plavix 5 days prior. We'll continue Coumadin, which is surprising for low risk colonoscopy, unless INR is super therapeutic, like 3, 4, 5. So again, average risk colon cancer, screening after the age of 50, no symptoms. I'm just doing colonoscopy. The patient is taking Coumadin because of VTE or because of metal valve. You know what? And the INR is 2.5 or 3 or 2.8. Therapeutic range between 2 and 3. Don't stop the Coumadin. Go ahead and do your colonoscopy. Number 5, stop the Coumadin for high risk colonoscopy with or without bridging. Here you go. Patient is taking Coumadin. INR is therapeutic, fine, but I'm taking a huge big polyp. It's high risk, sessile polyp. I have to stop the Coumadin. And if I'm stopping the Coumadin, go to and talk to the cardiologist and say, do I really need to bridge that or not? Do I need to keep heparin drip or something? It's a discussion between you and the cardiologist. And stop direct oral anticoagulation, either the morning off in low risk colonoscopy or 2 days prior in high risk colonoscopy. So direct oral anticoagulation, direct thrombin inhibitors or the factor 10A inhibitors, those will stop definitely. It depends If I'm doing average colonoscopy, I'll just stop them the day off in the morning. But if I'm doing high risk polypectomy, I have to stop them 2 days prior. So 6 guidelines that you can use if you are doing colonoscopy on somebody who's taking anticoagulant. We'll move on now to the second major complication, which we are more likely to deal with as surgeons than bleeding. Actually, if you notice that the management of bleeding lies between the GI doc, who may clip it or coagulate it, and it may come to us to operate, which is not that common. Here, we are often involved from day one with the perforation. What is a perforation? How we define it? Perforation, if you see the evidence of air or stool or instrumentation, like a scope, you can see outside the colon, that's perforation. How often does it happen? It depends, really. And the standard that people agree on, and you can judge yourself and gauge yourself and categorize your performance based on this. Your rate of colonoscopic perforation should be less than 1 or 1 in 1,000 or less than 1 in 1,000. Every 1,000 colonoscopies, you're allowed to perforate 1 or less, right? And if you are in a category of taking big polyps, we'll cut you some more slack and give you a little bit more of space, 1 in 500. So if your perforation rate in colonoscopy is 1 in 100, you're definitely in a bad shape and outlier. And something needs to happen about that. So the standard accepted complication is 1 in 1,000 if for diagnostic, or 1 in 500 if you're taking a polyp out. That's the standard. People agreed on that. How does it happen? It depends on the mechanism, right? It depends what mechanism, it depends on the type of colonoscopy that you perform. Diagnostic is different from therapeutic. And I want you to remember that. Diagnostic is really tricky. And the reason diagnostic colonoscopy perforation is tricky is A, you may not see it happening because it may happen somewhere, as we'll see, away from the lens of what you see. Second, and because of this, if you're coming to operate, you may not be able to know, or you may not know where the perforation is. You need some guidance. You need some localizing studies before you operate commonly after blunt or after diagnostic colonoscopy perforation. Therapeutic is a little bit different because you went in, you had a big polyp in the cecum, you took that polyp out with a hot snare, whatever, and now the patient has free air and sick and you need to operate. There is nowhere else where you were working around this colon. Very likely the perforation is in the right colon at the site of the polyp. So it's easier. If you're going to operate, you don't need localization much. But the diagnostic one is a little bit different because it can be a dilemma where the perforation happened. So how does perforation happen? Therapeutic is easy. It's where you took the polyp. Diagnostic is a little bit different. Diagnostic colonoscopy perforation, most commonly the perforation happens because of just mere force that you're pushing the scope through the colon. It does happen, but there are other mechanisms. The use of manipulation if the sigmoid is tight, or you can do that blind slide by technique that you lose the lumen and you push the scope still, hoping that it may just straighten yourself. That can be dangerous. Or sigmoid loops, as we talked about. Excessive force along the anti-mesenteric border. We'll see a picture of that, which is really important. Or just putting a lot of air and popping the colon, right? So here are the possible mechanisms in a diagnostic colonoscopy. A, you're just pushing the tip through the wall, too much pressure, okay? Look at B. B, you're up there in the transverse colon and everything is, to you, everything is fine. You're doing fine, but you're looping too much in a sigmoid, which you don't see. And this is what's gonna happen. It's gonna perforate here. You may not actually be able to see this at all. You would be lucky to see it on your way out, but you may not. And then you get free air, the patient is sick after surgery, and you're gonna operate. You have a problem here, you may not really know where the perforation is. You can see here a C, you're just pushing through a stricture or a tight sigmoid, right? And D is just putting too much air, just simple over-insufflation causing perforation. Where do you perforate most of the time? Most common is sigmoid. 50% of the perforations are in the sigmoid. Then you go after that to the right colon, then the transverse colon, right? Clues to an increased potential for perforation. Can I predict that? Can I go in thinking I'd better be careful because this is a high risk one and it may perforate? Severe inflammation like acute diverticulitis or colitis or C. diff. If the patient had previous operation and there's a lot of scarring and adhesions and the colon is bent and tented, definitely high risk. Patient with diverticular disease, that's what we talked about. So you really have to be careful that do not go in a false lumen when you have a patient with diverticular disease. See this picture here? This can be deceptive. You may think this is the colonic lumen. No, it's not. It's the mouth of a huge, big diverticulum. Do not go in there because you can perforate the colon. So be careful. So the risk of perforation also exists if colon is weak, such as Crohn's colitis or C. diff, and we all know this probably is a contraindication to colonoscopy in the first place. So always watch for adhesions, large diverticulum disease like tics, inflammation, colitis, always watch for this. Therapeutic colonoscopy, different risk factors than diagnostic that we talked about. Again, increases sessile polyp, large polyp, right side colon, because the right colon is often, the right colon has a thin wall, so the risk of perforation here is much higher. You see the distinction between therapeutic colonoscopy and diagnostic colonoscopy in the risk factors and the mechanism of perforation. So don't really put any bowel wall in your snare when you're taking a polyp out because you definitely increase the risk. Ideally, you shouldn't really be taking polyps larger than 2 centimeters if you're doing a polypectomy because you also increase the risk of perforation. Now, it happened how we diagnose it. Regardless of how we treat it, we need to diagnose it early because late diagnosis is a bad thing. If you ignore this, and I'm not saying that make the diagnosis and operate. I'm not saying this. I'm saying make the diagnosis and treat them. You may not operate, like Muhammad said. You may not operate, but at least treat them. Don't send them home because they're going to come back very sick, okay? So make sure you diagnose things early. Signs of perforation during colonoscopy. There are certain things that may guide you, may tell you that you have a perforation. Obvious during the procedure when intra-abdominal fat or viscera is seen through the scope. If you're doing colonoscopy and you see omentum or appendices epiploicae or the spleen or the liver with the scope, you definitely have a perforation like this. Huge big perforation. The yellow stuff, the pink stuff is the colonic wall. The yellow stuff is omentum and appendices epiploica. You have a huge perforation. This is not a questionable here. Other signs of perforation are abdominal distension, or if you're putting air and the colon is not inflating because the air is leaking, or the patient is telling you is moving around a lot with sedation, but getting a lot of pain. In fact, it is actually said that the most dangerous colonoscopy is colonoscopy done under general anesthesia for that reason. Because you need the patient to be relatively awake with you. So if you're pushing and giving a lot of pressure, they can warn you to stop and don't push too much. But if the patient is under general anesthesia, you lost this. You lost that safety mechanism. So try as much as possible to have some kind of a responsive patient with conscious sedation. Don't expect too much after the procedure. If you perforated the colon, don't expect when you get the patient to the recovery area that you're going to have peritonitis. You won't. And that's the problem. You have to suspect it. You have to have a low threshold to work those people up, because the colon is clean and it takes time to have peritonitis. So just because the patient abdominal examination is reassuring, it doesn't mean that there is no perforation, right? So the presentation of peritonitis may be delayed because of what we just talked about. You know, it takes time for the peritonitis to happen. Fever, leukocytosis, and sepsis may take hours or days. If you send this patient home, they may come back 24 or 48 hours and they're really sick. So any suspicion of perforation, what we do, we get a plain film of the abdomen. If the procedure was a little bit rough, if the patient is having some discomfort, don't ignore it. Don't send them home. At least get a plain film of the abdomen, right? And now we go in the story of free air and what free air means after colonoscopy. You have to be aware of this title, benign pneumoperitoneum. Benign pneumoperitoneum. This is a pneumoperitoneum after colonoscopy in the absence of perforation. And the mechanism of that is not clearly understood. Probably some splitting of the serosa of the colon and some escape of air. But the patient doesn't really have perforation. He's doing great. He's doing fine. Maybe the procedure was a little bit rough and things like that, and he had a difficulty in the procedure, and that's why you got the plain film. But the patient is looking great. There is no issue. He doesn't complain of any pain. And on the plain film, you see some free air. Don't operate. So maybe at most, just admit the patient and observe them. Or if you're really worried, get rectal contrast CT scan or something to reassure you there is no perforation. But just to remember of this item, benign pneumoperitoneum. It's a pneumoperitoneum that happens after colonoscopy sometimes. And here it is, up to 1 in 100 cases. And there's no perforation. And the air, some air escaped through the colon wall after a splitting of the mucosa because of high pressure, and that's what you have. It's almost similar to like benign pneumatosis of the bowel wall that you see in certain instances, and you never operate on. So just remember that. Another fact is the amount of free air after colonoscopy with perforation, that is. Now we're talking about perforation. And you see a huge amount of air, free air in the abdomen. It doesn't mean that, oh my God, this is really bad. This must be a big hole. No, it doesn't. Not always. And think about the mechanism. You're blowing air in the colon and actively, you only need a pinhole in that colon, small perforation to fill this abdomen with free air. So the amount of free air does not mean you have a huge hole. It doesn't. The bottom line is the presence of post-colonoscopy free air, intraperitoneal air, does not mandate surgical exploration, like Muhammad told us in the first slide. It doesn't. It may, but it doesn't mandate it all the time. Another important fact, post-polypectomy syndrome. This guy here is coming with pain after colonoscopy. You get a plain film, there's no free air. There's no free air, but he's having pain after colonoscopy. Again, does not mean a perforation. This is actually a common thing. What this is, guys, is not a perforation, but it happens after hot snare polypectomy. It is a burn. It's a 3rd-degree burn of the colonic wall that's giving serosal, visceral pain, and you get a plain film of the patient. There's no free air. You get rectal contrast. There is no perforation. You get a CT scan, and all you see is just thickening of the bowel wall, something like acute diverticulitis. So this commonly happens few hours, usually like next morning. Patient comes back to the ER after a colonoscopy complaining of pain. Watch them, admit them, give them antibiotics, they're gonna be just fine. There's no perforation. So far, we talked about free air without perforation. Amount of free air doesn't indicate how big the hole is. And here we're talking about pain after colonoscopy. Without free air, that doesn't mean perforation. It's titled post-polypectomy syndrome. You really have to be aware of this syndrome. They typically come with fever, some abdominal pain, and leukocytosis. Get a CT scan. You get pictures similar to acute diverticulitis. You admit the patient and watch them. Often they do very well and they go home. You give them an antibiotic. Now we're going to go to the actual perforation. There is a perforation. Definitely. I made the diagnosis. There is perforation. Remember what we said. It doesn't always mean an operation. So how are we going to manage that? Again, questions to answer. We need to ask ourselves some questions to be able to answer that. Number one, did the colonoscopist see abdominal viscera or fat during the procedure? We're doing a colonoscopy and I'm looking and I see the spleen or omentum. If the answer is yes, you need an operation. Especially if the colonoscopist cannot clip that to close it. But what that means is a big hole. And a big hole very likely will need an operation. So here's an easy one. If the answer to this question is yes, because we're going to have an algorithm later shortly here to show you guys. If the answer of that is yes, you're going to the operating room. Should the colonoscopist identify intraperitoneal viscera? This is what that says. The defect is big, you probably need an operation. Is the patient, question number two. Remember, now we know that we have perforation. Question number two, is the patient sick? Or is the patient asymptomatic? Or is the patient symptomatic but not too sick? Look at the patient. It's going to be one of three things. Patient is very sick, or the patient is asymptomatic, has free air, this perforation, but he's doing great. Or the patient is symptomatic with some mild pain, but not too sick. Each one of those has a different management. One, a patient with general peritonitis, sick guy, sepsis, easy decision, go to the operating room. Nobody's going to argue with you about that. So, number one, you go into the operating room if you saw a big perforation intra-op when you're doing a colonoscopy, or the gastroenterologist told you, I could see the spleen, you're going to operate. Another one that you go into the operating room is the guy who's sick, clearly sick. You go into the operating room. Number two, another easy decision. Free air, no, there is perforation, but the guy is great. Patient is great. No pain or almost nothing. Moving around, going up, getting up and going to the bathroom, walking around fine. Watch him. That's another easy decision. No operation. Number three is the guy that a little bit difficult. He does have symptoms, but they're not severe. But he does have symptoms and he's a little tender. This one, just watch that guy closer than the guy who's asymptomatic. Start antibiotics, repeat imaging, check on that guy very closely, because you may have to operate on that guy. Maybe keep him NPO, IV fluids and all this. The asymptomatic guy can probably eat and drink and you can watch him or can go home later. This guy is staying. One is going to the operating room, the very sick. One may be going home shortly after a short observation. This one here is going to stay. He's going to get antibiotics. He's going to be NPO, nothing by mouth. He's going to be watched. We're going to repeat imaging and we're going to watch him very closely. So another question that you need to ask yourself, how is the bowel prep quality? If the bowel prep was great, pristine, clean colon, guess what? I would be more reassured to watch the patient because there is not much stool in there to contaminate the abdominal cavity. Another thing is, if I know the bowel prep was perfect and I end up operating, guess what? I'm going to do primary anastomosis. That takes us back to the slide that not every operation means a stoma. No. If I have a perforation and I am operating and the colon is perfectly clean, totally good bowel prep, I'm doing primary anastomosis. So ask yourself, how was the bowel prep? Has implication on what you do in the management, right? And here's what it is. If the bowel prep was terrible, was really bad, and you have a perforation, watch. You'd be more inclined to operate on that guy because there's a lot of stool to leak into the peritoneal cavity. So take that in consideration, as opposed that the bowel prep was perfect. You're gonna say, you know what? I know there is a hole, but you know something, the bowel prep was clean. There is not much stool in this colon to cause peritonitis. So adequacy of bowel prep can provide clues to the risk of fecal soiling and peritonitis. And this may influence your decision. And this slide tells you just that. Not just this, as I say, clean bowel prep operation, primary anastomosis, good thing to have. Another question that you have to ask yourself, remember, we're still going through questions. We are going to ask ourselves to decide how we're going to manage this perforation. Is the diagnosis delayed? Did I send the patient home and now it's been 48 hours since colonoscopy? That's bad. This guy is probably going to need a laparotomy, and very likely he's going to have severe contamination of the abdominal cavity. Very likely that he's going to have a stoma, and maybe even damage control, like wash out and vac closure and coming back. Delayed presentation, significant spillage, and it's not going to do laparoscopy here. It's probably going to be laparotomy and very likely stoma. Another thing is, where is the perforation? Seen during the procedure, at the site of single polypectomy, or could be anywhere. Do I know where the perforation is? Remember the slide, diagnostic versus therapeutic? I am going to operate. Do I know for sure where the perforation is? Can you imagine how bad it is if you're operating and you're looking, flipping the colon right and left, and you don't find the perforation? What are you going to do? So ask yourself a simple, very clear question. I'm going to the operating room. Do I know where the perforation is? You might. You may be sure because the GI doctor tells you, I saw the spleen, so it's left colon. Or liver, or I took a big polyp. The only thing I did is I took a big polyp in the cecum. So very likely it's there. But if none of this, there's no polyp, I don't know what it is, it was diagnostic colonoscopy, I don't know any of this. So where's the perforation? In this case, you have to get some imaging. And what you do, water-soluble enema or CT with rectal contrast. You have to get that to plan your operation, okay? So does the pathology, remember the first slide, remember, the colon is prep, and is there a pathology that requires resections regardless? I know there is a huge tumor in the right colon, they biopsied it. So what am I waiting for? And there is perforation, and the colon is prep. Why are you sitting and saying, should I operate, should I not? You are going to operate because you're going to operate next month regardless. So just go and do it now. So operate and resect since the colon is already prepped. So another something that really needs to be considered. Non-operative management. So consists of this. We all know that: close observation, antibiotics, nothing by mouth. You know, watch the patient closely. If they deteriorate, you need to operate. Operative guidelines, number one, laparoscopy is very doable in the right circumstances. Patient is stable, not much contamination, you can do laparoscopy and you don't You can either resect or close. You can suture it, staple it laparoscopically. Don't think that the operation has to be open. Just remember that. Well-prepped colon, minimal fecal soilage. You can always do resection or primary anastomosis. And also remember, you should do damage control. If the patient is too sick, lots of stool, 2 days after the diagnosis, peritonitis, hypotension, don't go in there and try and do primary anastomosis or even do a stoma. Just get rid of the perforation, resect the colon, wash it, and put a temporary closure like vacuum-assisted closure, something like that, and come back and fight later on. Okay? Damage control. Okay. Not sure if the slide is frozen. I think my slide frozen. I just have 2 more slides to show. So basically, this is the algorithm that we're gonna go by, and that is whether you're too sick with peritonitis or not that sick. You can do laparoscopy, minus plus anastomosis. All these are important things that you have to consider. There was 2 more slides with algorithm. I can send them to you guys, but I can't, unfortunately, I can't get them on the screen for some reason. But that will be the end of our discussion, and I will take any questions and comments, please.
First, I would like to really thank you for this elaborative session. And if anybody have a question, just unmute yourself or go ahead and ask in the chat.
All right, any questions, guys?
Hello everyone.
Hey, how are you?
Hi, sir. I just would like you to repeat the procedure of how to do the damage control surgery for perforated bowel or very sick patients. I just didn't get it. If I go and wash out the abdomen, what should I do with the colon already perforated?
You resect the area and you leave the area stapled off. Wash out with like 20 liters of fluid or something like that. And that's it, and come out. And don't do anything else. And 1 or 2 days, put them on, leave the abdomen open, like we do with trauma, and come back in 24 hours or 48 hours when the patient is stable.
Okay, okay.
Just like the damage control for trauma.
Yeah, I got that. Thanks.
Thank you. Any other questions?
Hello. Assalamu alaikum. I've got a question. In case if the perforation is in the sigmoid colon and I can see the perforation when I've done it, any role for any endoscopic management like clipping using Ovesco clip?
Yeah, absolutely. If you have this ability, if you have the ability and yeah, if you have this expertise, yeah, absolutely, you can do that. But sometimes you don't have this expertise, and also the size of the perforation should be optimum. So for you to do that, sometimes if it's too big of a perforation, you won't be able to do that.
Thank you.
Thank you.
And any role for stenting there? No,
there's no role for stenting. Good question. No role for stenting, not like the esophagus. One day we're going to talk about perforated esophagus for sure. It's a very important topic as well. Any other questions? All right, Mohammed, is that good? Any other questions?
I think Dr. Rudaina, you are welcome. Hello, sir.
Okay.
Hello. I have a question, please.
Yeah. Go ahead.
In the intraoperative flow.
I'm sorry?
There, sorry, your voice is not clear.
Okay. Hello?
Hello?
Can you hear me, sir?
Yeah, I can hear you.
Okay, intraoperatively. Assuming, apart from the non-operative management of this patient when perforation has occurred, does the non-operative management, does it really depend on the size of perforation or not?
I'm sorry. Say this again. Sorry. What?
Okay. Intraoperatively, when you notice, assuming the surgeon noticed there was perforation.
Yeah.
And then the patient is not manifesting with any symptoms post-op, and you are managing non-operatively. That is non-operative management.
You mean post-endoscopy?
Oh, yes, endoscopy.
You mean intra-procedure?
Yeah,
You see that you create a perforation.
You create perforation. So the non-operative management of this patient,
depends on the size.
Sir?
You are asking that does it depend on size?
Yeah, does it depend on the size of perforation?
The perforation.
Absolutely. Large perforation, we're not gonna watch it. Yes.
Okay.
Yeah, large perforation, we're not gonna watch it.
Okay, sir. Thank you, sir.
Yeah, absolutely.
Yes.
Everybody. So my question is, if it was, let's say we did a colonoscopy for a biopsy, and the tumor is most likely inoperable, like large tumor, or so, and there is a perforation, and
Okay.
you say if the
ideal patient to go on and resect.
If it was the plan to start is just biopsy and it's not an operable tumor, it's for neoadjuvant treatment or something like that, and there is a perforation near site the tumor,
I would definitely operate. Definitely. I wouldn't watch that.
I'm going to send a comment and correct me if I'm wrong. I think in colon cancer, it is very rare to find an inoperable and irresectable tumor. It can be inoperable in the sense that it is a metastatic and might need a neoadjuvant at first to become, correct, to be like I think it's like a palliative session, and you can correct me if I'm wrong.
I'm sorry, I lost some of this.
I was saying that it is very difficult in colonic cancer to find one which is irresectable, even if like a palliative resection. Most of the time you can resect the tumor.
Right, and I think for the most part there is no neoadjuvant treatment for colon cancer anyway. For the most part. So yeah, perforated cancer, I would definitely operate.
Prof, I have two questions.
Yeah, go ahead.
It's clear in the first scenario and the third scenario. Frank peritonitis for surgery, asymptomatic patient, you can be soft with them and conserve them. But in the second case, symptomatic patient, moderately symptomatic, for watch and see. You said you can order imaging and follow up with imaging. I know in this scenario, clinical measurements will be better than imaging, but how often you use imaging and what type of imaging to use for those patients?
Excellent question. Yeah, imaging is not a replacement for your clinical judgment. You're going to use clinical judgment, but I would probably get a CT with rectal contrast in a day or two, just to make sure that I don't have a huge, big amount of free fluid in the abdomen. And you may be surprised that you don't see any contrast leakage, another thing. So I think definitely I would get that at least once with a water-soluble enema, water-soluble, of course, contrast, rectal contrast.
Yeah. The second question about the last question said by the doctor. Suppose we have patients well, with colonic cancer, stage 3, planned for neoadjuvant chemotherapy, based on imaging.
I'm not sure there is such a thing, guys. I'm not sure colon cancer patients get neoadjuvant unless it's a trial or something. But rectal cancer, yes, but which perforation
Suppose we have
is very
rectal
rare.
cancer. Suppose we have
Perforation of rectal cancer is very rare, and I would still operate, at least divert it.
Yeah, my question is, I read about the 5th type of perforation due to colonoscopy at the site of the perforation, and now it's coming rising with endoscopists. These type of tumors on the rectum, and the patient is the best plan for them for neoadjuvant chemotherapy.
Yeah, fine. Divert them. Do a laparoscopic.
Yeah, I can divert them, then I send them for neoadjuvant, then to complete the rest of the management.
Yeah, absolutely, yeah. But you're going to operate, though. You're not going to just sit tight, and you're going to operate, yeah.
Okay. On the other hand, the patients with perforation, they become peritonitic, but the site of perforation, we cannot assess it. What is the best?
CT with rectal contrast, 100%.
CT with rectal contrast, okay.
Do not operate on those people blindly if you don't know where the site of perforation is. We have very bad stories when people did this.
Prof, I know this is might
wrong
not be
side,
real, but
wrong side of the colon came out and they missed the perforation, and patients lost the entire colon, thoracolectomy, because they couldn't find the perforation. If you do not know where the perforation is, get imaging, water-soluble enema or CT with rectal contrast.
بروف طيب نحن نحاول نغير السيناريو شويه لانه نحن we have poor areas here in Sudan, we don't have the access to do CT with the rectal contrast.
Gastrographin enema.
We have some places here we don't have the access, we don't have the material to do that. What do you think of just to divert, then to send the patient for the center from one city to another?
I would just
suppose this patient has underwent colonoscopy, then 2-3 days later developed symptoms. He's going to be peritonitic. He's rising temperature. We have peritonitis. No facility to do CT with the rectal contrast. I don't know where is the site of the perforation. What do you think? To divert with urostomy maybe, then to send the patient for the center, or what? I don't know.
How far is the center? How far is the center?
This cannot be determined. ممكن لكن يكون 7-8 hours.
I mean, 6 or 7 hours, I'll just send them.
Okay.
I would just send them. I'm not sure why you need to divert here first. You know what I mean?
Yeah, I know.
So I would just 6 hours on, I guess you can send them. And he said there are centers that don't really have even the ability to do even enema.
Yeah.
How common is that, guys? How common for this to happen?
Actually, it's a very difficult question, to be honest. In Sudan, sometimes we don't have the full facilities for everything, but sometimes we have to try and work it out. Sometimes we don't have the full facilities for everything. You know, sometimes the investigation like CT scans and gastrography and enemas and everything is in the private sector. So sometimes it is very difficult for the patient to pay, and there is inavailability in some remote areas. Anyway, sometimes we need to bring like gastrography and inject it ourselves and then send it into the X-ray department for regular X-ray. So people just tend to try and modify things. But in the center, it's not difficult to find the investigations. Actually, this is difficult in the remote areas.
Okay.
But I'm just questioning if in a remote area there is an endoscopy, there should be an X-ray facility. And I think it is much easier to create a radiology department than to create an endoscopic department with all the facilities and repair and that.
Right. Can I was able to get the last slide that we missed, guys. Can you see this?
Please go ahead.
Hello?
Yes, please go ahead.
You can see it, right?
Yes.
Okay. This is try to put everything together, and I think it answers some of the questions that you guys had. So the diagnosis of ICP, intraoperative colonoscopic or iatrogenic colonoscopic perforation. ICP, iatrogenic colonoscopic perforation. During colonoscopy, you guys had some questions about that on the left side of the screen. The perforation is more than 2 centimeters. You had a question about clipping and all this. And if it's small perforation, low contamination, you're gonna do endoscopic closure. I know Muhammad had a question about that. If you have this ability, go ahead for a small perforation. If you have the perforation is bigger than 2 centimeters or a lot of contamination, you're gonna do laparoscopy. See that? No, the red one going down for laparoscopy. Let's leave that for now. Let's go to the right side of the screen. If the perforation appeared or you had the diagnosis after colonoscopy. Here's what you have. Small perforation, no sepsis, correct bowel preparation, asymptomatic or minimum symptoms. If all the answer to all of these, all of them together is yes, not just one, guess what? Conservative management. Look at this. Antibiotics, 3 to 4 days, bowel rest, all this. If the answer to these conditions is no, see where the arrow is going? Laparoscopy. Again, laparoscopy. In laparoscopy, the spectrum is wide. You can close it, you can resect it with ostomy, you can do primary anastomosis, and the options are here. You know, early surgery, good bowel prep, limited contamination. You don't have to put a drain, you can just do anastomosis and that's it. Somebody asked about damage control. Look at this little panel on the right side of the screen at the bottom, right lower quadrant of the screen. Very delayed surgery, diffuse peritonitis, hemodynamically unstable, previous multiple operations, very large defect, damage control surgery. Damage control surgery. Open, get all the stool out, resect the right colon, don't do anastomosis, don't do stoma, don't do anything. Wash it, put a vacuum assisted closure or something like that, a sponge or towel wet to dry, whatever it is, get the patient to the intensive care unit, let him get stable, treated for 1 or 2 days, bring him back, and very likely you're going to do a stoma or something like that. Damage control operation. Any other questions?
I would like to ask you a question. This is not in
Go ahead.
perforation. Actually, 2 weeks ago, we had a patient. He presented with colon cancer, some upper GI symptoms, and some bloating and abdominal distension. Then he went to a private center, had a CT scan, and then they found a tumor at the upper end of the descending colon, and just below the splenic flexure. His liver was studied with metastasis, and he had also some peritoneal seedlings without a fighting. And then he was decided to be for just palliative chemo. He's not obstructive, and his abdomen was soft. There was no symptoms apart from those sometimes distension on and off. We have a very good radiologist, and then in the CT scan he said that there is a microscopic perforation at the site of the tumor itself. And then there was a question. This patient is completely asymptomatic. So what is the best way to manage this patient? shall we just go and resect the tumor? It is a big tumor. Actually, we resect it, to be honest. We resect it.
You did the right
It was
thing.
a
This is the
what?
right thing. This is the
Yes.
right thing. You did the right thing.
Okay. We were just questioning because it was a big tumor. It had perforated over the gyrotous fascia. It was a sealed perforation through the gyrotous fascia, the left gyrotous fascia, and it was invading the DJ flexure. And then we have to resect the DJ flexure and did anastomosis and a gastro-covering gastroenterology. So it was like a big operation for the
Yeah, I
patient.
wouldn't.
His liver is studied with metastasis, so he's not. I don't think that he's going to have further surgery for his liver.
No, I wouldn't have resected the DJ junction. I wouldn't have done that. I would have left
Actually,
tumor in the abdomen. I would have resected that in an R2 fashion, meaning I leave gross disease in the abdomen because he already has stage 4. So
yes, he had stage 4.
I would resect the splenic flexure and do a colostomy probably, or do extended right colectomy and ileostomy, and that's it. That's about it. And if the tumor is attached, if the tumor is attaching to the small bowel or the DJ junction or the anterior to the pancreas or the geroda fascia in the kidney, I would leave it behind. I would just shave it off.
We did a colostomy for I mean, we did a limited resection in the colon, but at once the area of the DJ flexure was very difficult to mobilize, and it opened accidentally. Then we haven't any choice rather than to go ahead and take it out. And we did an osmosis. Actually, he didn't think that was good, but you know, we spent very difficult nights praying that he's not going to leak from the DJ flexure.
Yeah, this is a really bad area. I wouldn't have resected this.
Yes.
If he gets a leak at the DJ junction, is a very bad problem.
Yes. Now he's discharged, alhamdulillah, but you know, we spend very difficult nights.
Yeah, that's why what I would have done if the tumor was sitting in the DJ junction, I would have just shaved it off and left tumor.
Leave it like an R2 resection.
I'm sorry?
R2 resection, I mean.
R2, yeah.
Yes,
R2.
R2. With the macroscopic disease.
No. R2, because it's not going to make any difference. It's a palliative. It's a palliative operation. So I wouldn't
procedure. Yes.
It's a palliative. So I wouldn't have subjected him to the risk of DJ junction leak.
Yes.
All right. Any other questions?
Prof, I have one question.
Sure.
I think there is a gray area on the management of the rectal perforations, which is not accessible. Yeah, suppose we have a colonoscopy for patient حصل له rectal injury. He had a rectal injury. There is no experience to do clipping. Difficult to repair it. For me, as a general surgeon, not a colorectal surgeon.
Muhammad,
on the studies,
I wouldn't do any of this, Muhammad. Rectal injuries are, number one, they're very extremely rare with colonoscopy. Number two is, if you have a perforated rectum, the management is very easy. If it's extraperitoneal, you're going to divert it and leave it alone. Don't close it. It's going to close by itself. If it's intraperitoneal, you need to divert it and do something with the perforation. If this is for a healthy rectum, if the rectum has a tumor, you need to divert it. He goes to neoadjuvant treatment, comes back in 3 months for you to do definitive cancer operation. It's very easy.
I agree with that. But my question on the putting the drain, from your experience.
No drain. There are no drains.
No drain. Yeah, but this is my question because I watch a lot of papers. They're talking about pre-sacral dissection and putting drain on that area. I want to ask you from your experience.
No pre-sacral drainage. Done. Finished. There's none. The management of colonoscopic perforation, whether in trauma, gunshot wound, tumor, is proximal diversion.
Okay.
If extraperitoneal, gunshot wound, no trauma, no tumor, divert it in a sigmoid, it's gonna heal. You can close the colostomy in 10 days to 20 days. Very easy. There is a tumor, divert it, neoadjuvant, bring him back for definitive operation.
Thank you, Boss.
Thank you. Any other questions? All right, so thank you all, guys. Thank you for having me. Thank you.
Thank you very much. Thank you very much. Very
Thank you
useful,
very
very
much.
easy. Very
Take care, everyone.
patient.
Thank you.